Welcome everyone, and thank you for joining us for today's Data and Dialogue session. My name is Tess Conway, and I'm the Program Coordinator for the Urban Curricular Programs. This Data and Dialogue series was developed by Chicago Studies, a program of the college that offers curricular and co-curricular opportunities for the college community to study, engage with, and positively impact the diverse communities of our world-class city. The Data and Dialogue series offers participants a behind-the-scenes look at a Chicago-relevant dataset, archive, or other resource for research about the city. This session will introduce participants to the U.S. Covet Atlas, a visualization tool led by University of Chicago Research Coalition. In a quickly changing pandemic landscape, the tool connects COVID case data and community indicators across the United States from its beginning to today. The Atlas helps access current county-level data and spatial analysis to better understand the spread in communities and to bolster planning efforts. In today's session, we'll be diving into not only the Atlas itself, but also investigating how complex human-environment interactions impact the theory, design, methods, and infrastructure of research. Today's presenter is Dr. Marynia Kolak. Dr. Kolak is the Assistant Director of Health Informatics, Senior Lecturer of Geographic Information Science, and Principal Investigator of the Health Regions and Policies Lab at the Center for Spatial Data Science at the University of Chicago. As a health geographer, she uses open science tools and an exploratory data analytic approach to investigate issues of equity across space and time. Her research centers on how place impacts health outcomes in different ways for different people, from opioid risk environments to chronic disease clusters. She focuses on quantifying and distilling the structural determinants of health across different environments, tying political ecology models of public health with geocomputational methods and quasi-experimental policy evaluation techniques. She received the 2020 J. Warren Nystrom Award from the American Association of Geographers for her paper on distilling the impact of the recession on food access in Chicago, the 2017 Concordium Innovation Award at the Academy Health for her open source visualization of Chicago Determinants of Health, and Highest Impact Award in the prevention category at the American College of Cardiology 2019 conference for her work in connecting chronic disease rates with social determinants of health. She serves as the PI for the Atlas Project and multiple Chicago-specific air quality projects, and co-I and spatial analytic lead in the ETHIC project investigating the opioid epidemic in Illinois. In addition, she serves as a Health and Medical Specialty Group, AAG board member, and chair of the Chicago Public Health GIS Network. Welcome, Marynia.
All right, thank you so much for the kind introduction. And I'm looking forward to talking about what we'll be talking about today. So let's kick things right off. Okay. All right, so I'll be talking about a couple different things today, while I'll be focusing on the Covet Atlas specifically, a lot of what I'll be talking about will be positioning that within how we can best integrate geographic data science or geographic approaches within the landscape of public health, GI science, and that sort of thing into public health and policy. So first, I'll talk a little bit about my motivations and why I take the approach that I do. First and foremost, maps and visualizations have a really long role in public health. And because a lot of what I work on is within public health, I think that ends up being pretty important. So here you're looking at two of the first very well-known visualizations, specifically within Europe in the past, over 100 years ago. So on the left-hand side, we see a Sankey diagram. This is visualizing the march of Napoleon's army to and from Moscow. On the right-hand side, we see a Rose diagram from Florence Nightingale, who was also a statistician, that is highlighting different mortality rates that come from different aspects of war. I highlight these specifically because some of the first visualizations that emerged, period, were related to public health and also had kind of connections to greater social causes. So it wasn't necessarily the best method of visualizing something, right? So on the left-hand graphic, there's probably a better map that might visualize the exact pathway that the Napoleonic army took to Moscow and back. But the goal here was really to communicate something about mortality and war, and kind of generate, again, there's this kind of confluence of politics, social science, public health thinking. So some of the things I might talk about today may have different components of that. And I just wanted to note that there is kind of a tradition and precedence for that within the public health realm. All right, so another classic example is John Snow's work, right from the 1800s as well, the late 1800s, that traced the exposure of contaminated, or it traced an outbreak of cholera, an infectious disease, to a contaminated well. This is also a very well-known example of integrating kind of geographic thinking with public health outcomes and applications. Or is it? So there's actually some ongoing work through Thomas Coleman and Julia Koshinsky, both at UChicago, that kind of lift back this example and go through it in even more depth to kind of to distill these concepts a little bit more. But more or less, there is a strong tradition of GI science and then using data for different public health outcomes and strategies. Some things that's really changed the landscape in the last decade has been a discussion on the social determinants of health. So before COVID, there was a really strong focus. Public health had gone through a huge transition where for a long time, public health was all about infectious diseases. As you can imagine, cholera is infectious disease, right? Or war. So kind of, that's a different kind of focus of public health. But for the past decade and slightly before that, there was a transition to instead focus on chronic diseases and specifically the relationships of health outcomes from chronic diseases like heart disease, kidney disease, so on and so forth, and the different community contextual environment that exists. So this ends up being called the social determinants of health. And there's a lot of other names that emerge for this as well, but these are defined as factors, the physical, social, environmental conditions in which people are born, grow, live, work, and age. All right, so these social determinants of health, it turns out, account for at least 50%, if not up to 60, in some cases even 70% of health outcomes can be tied to these social, economic, cultural, environmental conditions, right? That's a huge proportion that that is pretty significant and impacts things quite significantly. And it turns out even in infectious diseases, these kind of social structures and political structures still have a role. So a while back, one of my favorite quotes regarding this is the most important 5-digit number. This person needs to predict your health status and well-being is your zip code, bar none. Okay, note here there's a prediction and an association involved with place. That's not to suggest that it's an actual place-based determinism, right? If you move to a different zip code, something is not magically transformed, right? It's a little bit more complicated that because of all the different social and political economic factors at place. But in order to study this, we really need to have methods and methodologies that incorporate spatial effects. So I do a lot of work in spatial data science for decision-making specifically. We know that if you don't account for spatial effects, geographic information, components and that sort of thing, it impacts the theory, the methods, and the technological infrastructure to do research. So that's why my focus is always going to be positioned within this really strong spatial perspective, because we need different types of methods, infrastructures, and then our theory gets adjusted slightly when you're looking at it with a spatial geographic perspective. There's a lot of different opportunities for spatial thinking in public health. And this was true pre-COVID. As you can imagine now, I'm not sure if we're post-COVID yet, but it still really matters. It's like one of the biggest topics in COVID right now is it exposure or is it vulnerability? Which one matters more? We know that COVID has impacted different communities differently. Is it because some groups are more vulnerable to begin with, or is it because some groups are vulnerable because of heightened exposure due to disproportionate representation as low-income essential worker forces, or differential access to treatment or differential access to testing for that matter, right? So there's a lot to kind of discuss in this area. And so again, my role, like I investigate how place impacts health for different ways for different people using a variety of techniques and open science tools. So here, I'm going to just shift to the next kind of standpoint. So that's kind of methodologically and from a framework what I do, but also increasingly, especially with all the complexity that has emerged in this topic, our lab is also really thinking about how to integrate even more refined frameworks to kind of provide conceptual understanding of what we're working with, right? So a lot of what we've been integrating recently is something called intersectionality. And this actually becomes a big player within the Covet Atlas moving forward, and we'll kind of come back to that in a minute. But intersectionality is a conceptual framework developed to better understand how systems of oppression intersect, interlock, and reinforce one another to produce disparate experiences, prospects, outcomes across a variety of different groups, right? This lends really nicely towards geographic information science and what we actually find in the results. A lot of what we do ends up looking at the intersections of health outcomes and experiences. And then different regions as well. We don't just look at urban areas, but we also look at how outcomes will be different in suburban versus rural areas. How does sexuality and gender experience relate when you're in different urban, suburban, rural experiences with different health outcomes? So each of these is kind of like another layer of an onion that we like to explore. And so just some texts that we've talked a lot about in our lab in the last year is the Black Butterfly and data feminism that kind of go into this in more depth. And then specifically within geography, there is also a tradition of thinking about space and actual place with this lens. So a really great text by Lipsitz talks about the racialization of space and the spatialization of race. We know that racism occurs at multiple different scales. And as geographers, a lot of the scales we're looking at will be a little bit more macro, right? So redlining is a practice that institutes very specific policy-driven lines at a macro level and that sort of thing. However, differential access to COVID testing, especially if it starts to fall across different lines of different populations of different groups, that can also create a different kind of dimension that we're looking at. So for those of you who are interested in this topic, or as the recording it comes out as well, our group is hosting a really big symposium next month where we'll dive into that even more specifically. Okay, hopefully you can see this. Okay, so I'll next talk just for a few minutes about a few small kind of projects, or all of our projects are big. So I'll give you a few small snapshots of existing projects, and then kind of dive into the main one that I'll focus on today, which is the Covet Atlas. So at our lab, the Healthy Regions and Policies lab, we will look at different dimensions and intersections of healthy places, from fresh food access to air quality, the opioid epidemic, the COVID pandemic, and then also more structurally, like the social determinants of health. Like, how do we measure them? How do we actually implement that understanding in these different topics? So a recent project, as a kind of small example, is measuring the Great Recession impact on food access. This is the previous recession, not the one that we're in right now, but the Great Recession from 2007. So this one ended up incorporating an extended spatial counterfactual framework. So bringing some spatial econometrics into causal inference research to actually measure causally the impact of the Great Recession on food access. It turns out that the areas that were at the greatest risk of food insecurity during the recession were also more likely to be structurally segregated and have already high economic vulnerability. And it seems that the kind of predatory lending practices of the recession may have, again, generated a compounding crisis, whereas areas that were at less at risk of food insecurity also were less likely to experience strong factors of of vulnerability from the recession to begin with. So that's one example. Forthcoming. Another project this is actually a series of projects, but one I'll highlight here is looking at open air quality in Chicago. So we know that air quality and pollution also impacts health, but it gets really complicated because it's hard to tease apart exposure versus vulnerability, right? Which communities are most exposed to versus most vulnerable to PM 2.5. It turns out the Loop has a lot of air pollution, for example, but that's a very different group of individuals, both from a demographic perspectives as well as health profiles and income levels and that sort of thing than areas on the far west side or even further south side. So we use a variety of different techniques to actually measure air pollution at fine levels. And we partner with the Chicago Department of Public Health to make that information accessible to policymakers, health scientists, and ultimately the public. So this is just an example of one of the projects that we did where we, again, we know that the pollution that we focus the most on is PM 2.5, which is a very, very fine particulate matter that gets into your lungs and may cause acute and chronic health problems. It turns out that the best quality sensors we can get for this that are ones we can really trust because they're well calibrated and well sampled are the EPA ground sensors, but there's not a lot of them in the area. So that creates issues. So we use some satellite data to kind of calibrate and fill in the missing gaps through that. So long story short, we end up using a statistical framework with kind of machine learning techniques to investigate this. So specifically, we extend an existing model with a neural network, and then we get monthly averages of PM 2.5 across 5 years. We match that 5-year resolution with the same resolution that we have for health data from other kind of components. So this is done on purpose. And from those averaged results, we see a lot of places that make sense. It turns out a lot of quarries in the suburban areas of Chicago have slightly elevated PM 2.5 levels when you're averaging it over time. O'Hare, I-55, that sort of thing. Yes, so, and we also, because we're spatial nerds at heart, also extend a lot of thinking into how to even, there's a lot of different variables that go into this model. And that, so for example, in the upper right corner here, you can see different sensors that are capturing different types of meteorological data that we need for the model. Well, turns out there's a number of different ways that you can represent that and put that in as an input into the model. So rather than just choosing one, like that's often done in the literature, we do a sensitivity analysis, decide which one is the best one, use that, do the same process for the next variable, and so on and so forth. Because what we do has to have a policy dimension and make it easily accessible, we develop dashboards for it. So here, the dashboards are done in R Shiny because the community we work with for this project is familiar with R more so than some other languages. So there was some reasoning there for it. And again, creating an interactive dashboard for it. And then as an extension of this too, there was a lot of interest and passion around, what do you do about this kind of, sometimes because of, and this is going to relate to COVID, it turns out, so air doesn't just stand in one place, right? things tend to move. There's a lot of spillover happening when you're talking about place-based data, and especially with air pollution, sometimes the causes of the air pollution are outside of the city boundaries, and that makes it very difficult for policymakers who want to do something about it, right? They might not have control outside. Essentially that becomes kind of a lobbying activity that has to be done at different levels of government. That's going to be, in Springfield or DC. But locally, there have to be things that we can do. So one thing that everyone could kind of agree around and get excited about was trees, right? Well, we can plant trees in areas that have, planting the right types of trees in areas that have high pollution, high social vulnerability, high surface temperature, high flooding susceptibility, and that sort of thing. So we worked with them to develop a tree toolkit to kind of bring these pieces together. And I highlight this project just because it really captures kind of the different dimensions that were coming together, and it ends up being a different, very local project compared to the Atlas. Okay, so let's get into the COVID pandemic in some detail. So this is a project that we took on at the end of, well, yeah, I guess right around March last year, so over a year ago. Thinking back to where all of us were at March 1st, 2020, from a kind of a spatial analyst perspective, again, having have done some work in, the opioid epidemic, and having have worked with different groups at different levels of government and, different university settings, um, there is a lot that proved to be really big kind of technical and methodological challenges at the beginning of the pandemic. There was a lack of publicly available county level COVID surveillance. This tends to kind of miss hotspots um, that are growing rapidly, because in order for a hotspot to be a hotspot at the state level, it has to be pretty massive, right? So this, if you don't look at the local level before you focus on the state level, you can miss some of this really important information. At the same time, there are a lot of public tools that generally focus on cross-sectional views, so just one point in time, as well as static maps. Maybe you have a map that you can click on, but at the very least, you can't look at multiple time points. A lot of the groups, or a lot of the technology was really fitted to who had access to the technology. So Chicago had a lot of different options, or more so than other areas, because there's more analysts and data scientists and experts within Chicago. If you're living in a remote part of Arkansas, it's just simply not not the same. So not all groups could access sophisticated spatial analytic tools, multiple data sets of differing quality, no authoritative source, which continued to be the case until late December this past year. And also a need to quickly integrate community factors for context for various applications. Knowing all that we know from public health, all the stuff I talked about at the very beginning, social determinants really matter. They may account for, up to a half of the health outcomes that we have, and we need to integrate those factors quickly in order to investigate what's happening and why it's happening. Otherwise, you get into a lot of really sketchy, not totally, sussed out hypotheses that kind of make the error of correlation equals causation, which is not the case, right? So that actually happened with air quality in COVID. So some of the earliest work had not completely taken that all the way through, and so on and so forth. So long story short, our group developed the US COVID Atlas, which is a clustering surveillance and data visualization tool that provides quick access to county level Covet estimates and statistical cluster detection. So while our group is leading it, we're actually leading a research coalition of multiple different groups. In the early stages, we worked a lot with a data science group at Madison that had connected us to County Health Rankings, which is a national, really phenomenal program that focuses on county health factors specifically. We worked with Department of Statistics at Berkeley, as well as with a national network of rural health practitioners and different folks working at those different scales. And then also our approach was from the earliest stages to keep whatever we do open source, open science. The goal was not to get a bunch of shiny research papers. We're finally, a year later working on that now, but the goal was just to provide the standard of what is accepted and, expected in the kind of GI science world, free and accessible for the community at large. So at this point, and this list is always expanding, so we include a variety of different data sets, generally at the county and state levels, because one of our prerequisites is the data has to be available for the country, not just one city or place at a time. We try not to make the error of only focusing on cities, because a huge amount of people live in rural and suburban areas, and we don't want to overlook them, because there's also a lot of additional barriers to healthcare access and success in those areas. So again, we're trying to address those in our research method design and not make the compounding crisis even more dramatic than it already is. So, okay, so we include, confirmed cases, deaths from multiple different data sets, adjusted for population, adjusted by hospital bed available, positivity rates. We also now have vaccination rates, and this list is always growing. We have different pandemic insights. So we use actual statistical clustering algorithms called natural breaks to determine how to show the data, because how you show the data can really influence how you think about it. We include statistical hotspots and cold spots, and so on and so forth. And then again, a lot of different social, economic, environmental data sets, and also mobility data. I'll highlight some of this in a super quick demo. So I've already talked about some of these methods, but a big feature of this is keeping things interactive and exploratory so that the user can use all the information that's available on the atlas to explore to their heart's content and really dive into their specific question. And that makes a big impact. So another feature is having, not just exploration at the spatial scales, but time scales. So you can explore different times to look at the history of the COVID pandemic. So the bottom here, you'll see myself, Jiming and Schwinn, who we were the three kind of co-authors that started this whole thing to begin with. We also have a lot of questions often of like, who is the COVID Atlas for? Who uses the COVID Atlas? Initially, the COVID Atlas was really targeted towards health professionals and health policymakers at kind of different scales of government. So knowing how things are at local, state levels, and focusing on under-resourced areas. But it turned out that a lot of other people started using the Atlas along the way. So who uses the Atlas is going to be different. We have journalists using the Atlas to investigate regional stories or national stories. We have teachers using the Atlas to both teach pandemic versus we also have folks teaching, using the Atlas to actually teach principles of mapping in general, right? And a lot of things along the way, as well as a lot of other folks. Something to highlight here is the technology used for the Atlas is some features are brand new. So a lot of the calculations that are being done are actually being done on the fly in your web browser, which was previously unheard of. So Schwinn is our mastermind behind that, who pushed out the JS Geoda module that is doing some of this. And now a lot of this work is being extended through Dylan Halpern, which is our new principal software engineer. So, I mean, obviously Schwinn is still retains a lot of work on this from the beginning as well, but it's been great to have Dylan come on this project as a full team member. And we also have, and so here on this picture, you can see Dylan on the bottom, the second to the top. There's also a shared and managed data integration system where data is coming from multiple different sources being processed in different ways. Some of the data is being processed on the fly within the actual application itself, but a lot of it is being processed within a server that sits on AWS. And we now also, all the information that goes in can also get piped back out through an API for developers. But then also Dylan recently added the opportunity to download just, using a point and click method. Okay, so ultimately the Atlas follows its namesake, right? It's an atlas, it's a curated collection of maps and data. It's not really meant to be a dashboard in the traditional sense, which is more of a at a glance overview or report type structure. So that's a feature, not a bug. Our goal is to provide a more personalized and depth experience that considers uncertainty in multiple perspectives and design. And we also use participatory design methods in how we developed it. So we're constantly tweaking and updating the Atlas, not according, sometimes according to what we think we want, but we always kind of vet a lot of the core changes made through the different, users, coalition members, and that sort of thing. And this is always changing and getting refined over time. Another really big part, it turns out, I know this will be shocking to hear in a data and dialogue session, that for a lot of people, data isn't enough. Facts is not enough. There turns out there's a bit of a, I've heard it called COVID fatigue, dashboard fatigue, you name it. Data is not enough. We really need to translate. And that's one of the big lessons learned from this year. We need to translate these insights. So we engage artists, graphic designers, librarians, community members, a pastor, and many different advocates from different fields and more. To kind of connect what we're trying to do with their perspectives and translate those insights. So that's been a huge piece of what we've been working on as well. And along the way, we've kind of come across a couple different pretty big aha moments. So we were some of the first to identify, actually measure, and sound the warning alarm for identifying vulnerability in rural areas. So we had identified this really early on, like at the end of March 2020. Once you adjust for population, it became, and use again a statistical hotspot method, it became really clear what was happening. And that continued to, dramatically increase as time went on. So a lot of the summer months and what we saw there made a big impact. Moksha Mangeni, who used to be with us, had a big part in crunching the numbers for that. One more, oh, I didn't mean to do that. Okay. One more piece before I shift back to Chicago is identifying hotspots that were specifically happening in rural areas in the South that had higher proportions of African Americans. Traditionally, this is known as a Black Belt, a swath of community or of counties across the South. There's a really strong legacy of slavery and deinvestment. Well, I mean, deinvestment might not even be the right term, because there's a lack of investment to begin with in these counties. So we were able to track that in real time, and some of our colleagues who were had connections to this area even use the atlas to do some policy advocacy work, specifically in Arkansas. But another piece, and this is where we really come back to Chicago, is no matter where you look, spatial spillover of COVID is a really big problem. What happens in one county or one state is going to impact its neighbors. And I'm not just talking about COVID cases, I'm talking about social behaviors, attitudes, differing policies. There's a tendency to focus on one's own place in a lot of research, and that includes public health. And when we do that, we kind of forget that, again, the influence of nearby areas. So different policies will have attraction and repulsion behaviors. That's true in taxes. That's been a well-known spatial spillover documented from years or decades of economic research. But we saw that in early June between California and Arizona, where there was very different policies in place, and you suddenly saw hotspots creep up in Arizona and then slowly start to filter through California. There's many different vacationing, isolation, recreation seeking behaviors. This was really obvious in Chicago last summer. You may be part of that memory as well, where we have to stay home in Chicago, but hey, I heard that Wisconsin is accepting tourists, right? So we can go to Wisconsin, we can go to Michigan, and so on and so forth. So there's another, the New York Times did feature the atlas in one of its works at the beginning of the pandemic, where they were able to use the atlas to show how vacationing behavior, well, maybe this is more isolation seeking behaviors of New Yorkers going to their recreational homes in the suburbs of NYC actually shifted and developed some hotspots from that perspective. There's also different commuting behaviors of essential workers. That is going to be a big factor. And then also differential attitudes towards COVID. While individuals have certain behaviors, those behaviors tend to exist as groups as well, right? So the attitude of Chicagoans overall, if there is such a thing, is going to maybe be different than a rural part of Wisconsin, 2 hours north, or vice versa, right? There's going to be, our attitudes are also tend to have a spatial signal. And these are all things we need to think about. So what protects a county with strict policy regulations from nearby regions with more relaxed rules, right? There's no, and at this, I mean, from what I understand, we never had such a strict policy where you would be physically barred from entering an area, or very, that might have happened in a piecemeal perspective, but overall, even if Cook County had a really strong regulation for COVID, that doesn't mean the suburbs did, right? And we know that social behaviors also don't have strong physical barriers as well. So social behaviors also shift across those borders. In a minute, I'll show kind of a bit of a demo, but I can also hold on that to the Q&A. So takeaways of what we learned in this past year, but also note the system is still not at equilibrium. So it's really difficult so if anyone tells you they've, found the answer to COVID, you can be 100, or I mean, COVID as a pandemic overall, it's not possible because our system is still not in equilibrium. We still don't, all the things that we could count on of behaviors that were assumed, none of that exists at this stage. So we need to continue to integrate exploratory data analysis to support pattern detection, data exploration, and then continue to refine our hypotheses as we go. And that's a tradition that has, again, some serious precedents in science. We need to distinguish and make distinct spatial and temporal COVID profiles that will be emerging at different regional scales. We need to highlight areas with legacy racist and colonial policies that will help impact the disproportionate toll of the pandemic on communities of color, right? So these things don't ever happen in isolation. You're going to find markers of that in the spatial data. And then finally, again, access to data and methods is not enough. I hate to end on that note, data and dialogue piece, but that's a really big piece. So one thing here that again, Dylan Halpern and our group just came out with is a storytelling map of all our US COVID deaths. So this takes you through a couple different cities, but essentially it's, I'll let it speak for itself in a minute. I can drop in the link in just a minute as well. But as you scroll through this, every scroll will populate different parts of places that you may be familiar with. Here, I'm showing you the Chicago version, so around the Bean and Millennium Park. Every scroll you take, as the death toll increases, as you go through time, we're filling in the areas with people who've passed from COVID. And just the sheer volume becomes really staggering as you go through piece by piece. So we've learned again that in order to engage data and dialogue, we really have to think of new ways to communicate. So here, I will first, first I'll highlight this. So here again is the atlas as it is. I have zoomed in to really highlight Chicago. And it always starts in the most recent data. But now as we're kind of, again, at this nearing the end of the pandemic, hopefully, what might be interesting is to look at the start and to really see how things kind of started things out. So you can see Chicago is the first county in our region to have the first COVID case that was documented as well, right? And then that really starts to very slowly change. So, obviously, the virus didn't just jump across those different counties, right? It's likely that we had undetected cases, but as you can kind of progress over time, here we're looking at the population adjusted feature. You can really start to see how things emerge over time and explore, different periods of time, like look at the traffic post Labor Day or around the holidays and that sort of thing. Another part is, so normally I always recommend looking at the rate adjusted, but it's also important the total number of cases in general can also be important because that's just more, bodies for the virus to, incubate and inhabit and that sort of thing. So both the number and the rate adjustment are really important. And that starts to really highlight in Chicago specifically. So here I'm switching to the statistical hotspot map. Red is going to stand for areas that have disproportionately higher COVID numbers, and its neighbors also have high numbers, okay? So starting here, we can see that at the very beginning, we had something, but it might not have been as much compared to all the other counties in the US that had COVID. But again, it's probably at the very beginning stages a testing issue more than anything else. So here you can start to see how that changed. And as we start to see the filling in of COVID by, April, you can see that the hotspot is pretty persistent throughout, and it starts to spread, it starts to come back. And again, you can really see how things are shifting over time, which can be really interesting. So by October, you can see, what was very likely a big, there were a lot of things happening at this time, but you can start to kind of, again, refine different hypotheses of what you might expect was happening at that period. And the other really nice part is that you can also explore a lot of other options. So say you want to look at, you want to test your hypothesis. Say, well, I think this is because of, of when people were actually staying home or not, right? So we actually have percent full time on work days. So at the very beginning, people were working pretty normally. The lighter you get in this map, the more people are staying home. So here you can start to see things starting to change. In the March period of last year, you can see that people are staying home, taking those policies rather seriously. And then suddenly by the summertime, it's going to start to change. So you can, again, this is more meant for you to explore on your own. You can see Indiana has started to come back to work. And some things are really starting to shift. So even though the Chicago area specifically is, holding down the fort, so to speak, all the areas around us are not necessarily. So that's going to really impact the results. And then finally, other, variables you can use to test your hypotheses would be things like the testing positivity rate, testing capacity, right? You can use that to see whether or not at the very beginning, whether or not it, is it because of testing or is it because there's just more COVID cases, right? It turns out there's a bit of both happening at different time periods. And then more recently, we can look at vaccination rates, and then also look at things like percent essential workers, which also ends up being pretty important. So this is a static data set. It's not going to change on a daily basis like the other one, but just something to think about. And then finally, I'm going to go to the insights. And just for my last minute, again, this is hot off the presses. But here, if you look at the map, again, this type of work is kind of the direction we're going, and is how can we really elevate specific stories that have emerged from the US COVID Atlas, summary of work. So here, again, as you continue to scroll, you're going to see more people emerge at different time points. So this is in April, where the death toll was near 11,000. Now we're in May, where the death toll has exceeded 75,000. By late summer, you can fill this entire section around Buckingham Fountain, right? And now today, we can see again. So, well, actually, I think I have it in this last one. So at this point, this is at the time that this was made, we had lost over 555,109 people. Okay. So again, just to kind of highlight the dramatic toll that this has taken. So at that point, I'll stop and I'll pop in some links. But yeah, let's see if there's any questions.
Sure, and while maybe other people are putting their questions in there, I thought maybe I would throw in some of mine first. But my big question was, you talked a lot about the importance of incorporating what you called advocates in like sharing this information and making it more, maybe not more accessible, but just something that was more in front of people. And I was just wondering if you had like an infrastructure in place when reaching out to these groups of people, like how did you do that basically is what I'm curious about.
Yeah, so I think in some ways we lucked out because in many cases others connected those people to us, or sometimes people just ask us directly, right? So I think a big part of this is making information accessible as much as possible on the site. So making our email addresses available on the website. So if you have questions, you could email us. Some people emailed us kind of challenging what they were seeing on the Atlas, right? And then it was like, oh, well, hey, like, we're happy to talk through this. If you have information that, the health departments don't have, I'm sure they'd appreciate it too, right? So keeping kind of like an open door policy for email exchanges ended up turning into some really interesting conversations, relationships down the road. As people also shifted in different roles through the pandemic. Like we had one person who was in charge of one of the big projects that was leading one of the research coalitions. And then at some point they switched to being a full-on like public health advocate with very specific focuses. And so that relationship had already been connected. But again, we were introduced to that group through another member of our coalition. So I think a lot of the work happens more organically through your approach in general. versus like having a bunch of names and doing cold email calls or something like that, where there has to be some like trust building that goes into it to start.
Yeah, that's really interesting. So I used to work for a collaborative, and it was just like getting those relationships built and trust is like a really long process, and usually like happens over many years. So I was curious to see like, was that high speed in a time like COVID? But that's interesting. Yeah.
Yeah, and in the next 2 years, the kind of future stages of the atlas is going to be even more relationship building through like the network that we have to kind of extend to more community organizations and so on and so forth. So it seems like you have to grow spherically in that space. There is no linear path. And so just, yeah, kind of like diving full on into the relationships you do have, and then at some time that will kind of lend to other connections and relationships and that sort of thing.
Marynia, there were so many things that were so interesting, and I unfortunately have a long list of questions, but I'll email to you if I can't get all of them in now. I would love to hear a little bit more about what you've learned about the sort of the data analytics inequity between urban and rural spaces in this country by doing this project. I thought that was such a revealing set of comments. And I'd just love to hear a little bit more about that and sort of the implications coming out of this pandemic in terms of sort of where we can go to kind of remedy some of that.
Yeah, no, and it's so complicated. And I think part of it is because fundamentally there's like different suites of challenges happening in each of these places, right? And that's where if you try to lump all of it into one regression model, you get really strange results. And we've dealt with that for other projects for a while, and it can, yeah. So, I mean, for example, this happened with the opioid epidemic as well, where cities that have more resources, right? So if you were to kind of look for what's the relationships on access to resources and opioid deaths, but you could do the same thing for COVID deaths, right? Well, places like cities that have a lot more resources, if you look at it from that perspective, may also have more opioid deaths or COVID deaths, but it's not because they have more resources. It's because of other really complex reasons, right? So, so yeah, I mean, with COVID, that's a great example where, yes, like cities were some of the first to get access to testing. With vaccine, the same thing played out, but it gets more complicated because vaccines also need refrigeration. So there's this whole kind of logistic, optimization problem that has to be accounted for. And then on top of that, you also have fundamentally like a very heterogeneous kind of, social behaviors, communities, ways that information is communicated and that sort of thing. So some of the majority of questions that we get from the Atlas are from rural or rural adjacent areas. And people will email us saying like, is this real? Because like, I'm hearing something different from my policymaker. And, so the ways that information are shared are different. The pathways, or even like how communities talk about problems, are different. And because of, histories of de-investment, and the academy like doesn't do a great job explaining things either. So you also have folks who are trying to explain what's happening, but it comes off as, not believable, or at best, or intentionally like malevolent at worst, right? So yeah, I think that it's just a very different way of doing things. It's funny, like I remember, so my family came from the farms. Like I'm the first generation city dweller in my family, but I learned all the lessons of what my family said. And I was much like in college, I actually studied geology. And one of my jobs as a geologist was to do soil sampling, or like to actually do core sampling in the middle of the farms in Southern Illinois. And I remember my boss telling me like, this is going to be a horrible experience. People are going to be like questioning you every other day, and just being outright aggressive, right? He was like a total city slicker. So we went out there, and I learned that as people were driving by, my boss would look down and kind of like turn around in the opposite direction. And the way that my like family or like farm family raised me is like, you have to, you have to wave, you have to look approachable. So I did that, and sure enough, people started to come up if they drove by, and word travels pretty fast. And I just engaged in conversations, and it was actually a really pleasant experience. Like back then, Napoleon Dynamite had come out, so that's aging myself. And I had a hat with Liger, the Liger from that movie. And one of the farmers, that was his favorite movie, it turns out. So, he didn't mind us drilling, next to his farm because of that, right? So you get these weird kind of connections, but it's also a very different way of communicating, right? Whereas like that wouldn't work in the city if you wanted to expand a vaccination program, right? So I think that we have to like not just acknowledge those differences, but also get people on board from those. So there's really smart people in rural spaces and suburban spaces and places of from these different backgrounds, like actually working with them instead of working at them is going to make the biggest difference.
Which to me, just is that much greater of an endorsement of kind of the open science approach that you're advocating, and such a great
Totally.
help for it. I was also intrigued by your kind of spatialization of Crenshaw's thinking about intersectionality. I was just, you couldn't hear me because I was muted, but I was literally giggling with glee as I saw you talking about that. And we'll be sure to drop a little bit of Crenshaw into the margin notes for the talk on the website as well. But I think one of the things that Crenshaw talks a lot about is the ways in which kind of an intersectional perspective can often destabilize things that we think about as more or less obvious binaries. I think urban rural is one that probably gets destabilized pretty quickly. I'd be curious, as you've been kind of bringing this more intersectional perspective into your spatial analysis, where have you seen maybe sort of surprising intersections or data where you're like, the one that leapt up to me that I was particularly amused at was in an early slide, and you like, and here we have a mystery spot of bad air quality that we can't figure out. But I'm sure that you have other kind of mystery spots that have shown up in other analyses that you've done, particularly as you get more intersectional. I'd just be curious to hear some of those that have been intriguing to you.
Yes, and I think that part of this extension is pretty recent, and it's been, I mean, the biggest part is to like trying to be as naive as possible every time I go into an analysis, which can be really hard, especially as you get further along. So I feel like working with students who are super new to it is really helpful because, you have to have like, I mean, you have to be a skeptic of your own biases always. So that's one part. But other things are like, for example, growing up in the US, and I'm daughter of, farm folks, but also like one of my mom immigrated. So there's a bit of like America, exceptionalism, I guess, through the immigrant story that happens sometimes with first gen folks. And a part of that is like home ownership, right? And as a, also millennial, like home ownership is a really complicated topic, especially post-recession, that sort of thing. But so recently, so the recession article that I had mentioned, a paper I'll be presenting on this week is looking at the trying to explain hypertension rates on the south side of Chicago based on neighborhood factors just by themselves. So how much can we predict hypertension at this one at this one major clinic across the south side just based on neighborhood factors? Well, a lot of the traditional players come across, but it turns out that home ownership was one of them. So areas with more homeowners was part of it, but why? Well, it turns out it wasn't home ownership, it was foreclosure risk, and specifically foreclosure risk in aging African-American neighborhoods in Chicago. And the reason they were aging was because these were areas that were middle class, African-American homeowner areas that were then subject to predatory lending that was specifically targeted, that was then impacted by foreclosure. So foreclosure had one of or foreclosure risk from the Great Recession had one of the strongest predictors of anything else. So it looks like, so the translation is what? So if I buy a home, I'm going to get hypertension, right? No, it's a lot more complicated than that. So I think that really kind of trying to dive into the story and going beyond the attributes. A lot of clinicians I work with are used to like controlling for, or you like account for, you know, race, gender, age, right? So they're like, well, of course, areas, you know, that have more seniors are going to have more hypertension. But then it's like, why do these areas have more seniors? Like, that doesn't make sense, right? That it's not like a Florida retirement community right here, right? So it turns out that, yeah, so I think part of that is, but again, that finding is not going to hold in a Florida retirement community because there's a different tradition of foreclosure and predatory lending in minority communities and that sort of thing. So, yeah.
I'm also curious. I know that, you know, I'm stopped because I have a million questions, but Ms. Schmitty, you pulled you go for it.
Yeah. Thank you, Professor, for such a great talk. I just had, like, since I have taken a lot of classes with you, so I just had some questions going back to those classes. Is that aggregating the data at these spatial units? I mean, okay, so how did the COVID Atlas inform, if it did, the vaccination programs? And if it did, then how does the area of aggregation sort of impact, like the understanding of where should the programs be more concentrated, between what age groups, and like especially like if those areas or neighborhoods have frontline workers? So I just wanted to understand the relation between these aspects.
No, these are great questions. So there was no direct relationship between access, like this was not informing, and I think part of that is because of the transition of the administration, right? So that this was not a direct informant of where things go. However, our coalition told us back in December that it was likely to be happening at federally qualified health centers. So Dylan had pulled that data, and I see he's on here too, so feel free to say something. He pulled up some of that data back in December. So we were actually prepared like 3 months ahead of time for when that announcement formally came through the administration, right? So this is where your coalition is important. So we layer that on as an additional data set. It's really interesting because you'll see the disparity in access to FQHCs pretty quickly as you add that on. And a lot of places were invited, but not necessarily accepting the invitation to become like dissemination sites of the vaccine. And those areas tend to be in very rural places. So yeah, so I think it's tough. And then to your point of spatial scale, the biggest challenge in working on the Atlas has been that this is our analytical scale is a county level, but I don't think that's the phenomenon scale. I think it's happening at a smaller resolution, but we don't have that data and there's no mandate to make the data at that level. Like we need clinical champions at high levels to say, like, we need at the very least zip code data. I mean, that's still not great, but we need someone at that level to advocate for that. And it's, yeah, so that's probably our number one question all the time is like, when are you going to add track level data or zip code level data? And our response is the same, like, because if we were to do that now, guess who would have it? The cities, which is great for the cities, but then it's like, we're trying not to like reify inequity by like only putting the best data in the cities as well. So it kind of comes back to that challenge as well.
Yeah, and just a follow-up question was that at least in the US, I noticed that there were a lot of rises and falls, especially for cities that were, initially not even in the top 10 of, having the highest number of cases. And just like after a few months, they were on the top, and that cities that, we heard that, okay, they're having a really bad situation with respect to cases went at the bottom. So what kind of behavioral insights did you get about, political will and administration, and just in terms of like just the behavior of people because of this entire thing, because obviously it went on for way longer than people expected it to.
Yeah, I think that's such a great question. And I mean, part of this is we have to like specify this in a model to really be certain. But I think at this point, like my hypothesis is really around where the spatial. So for example, Cook County is such a great example of this, where we had really strong policies throughout. And as we saw, like as Chicagoans, we saw repeatedly those, you know, all the parties that happened, all like, I mean, my favorite, the mayoral memes, like her showing up at different places, right? But then also like, like what happens in Milwaukee, Wisconsin, or the Dells has a big impact on Chicago, and the mayor will not have anything to say over that. She can make, like, you can get all the recommendations we need. Like if you're coming from a COVID hotspot, you know, please quarantine, but how do you actually communicate that? And this comes back to like data is not enough, like rules are not enough. Yeah, and like I live on the southwest side of the city, in the city, but next to a bunch of suburbs. And in the suburbs, everything was open. Like I have permanent lines drawn in my family of like who went out for like buffet, you know, meetings every Sunday. Like I'm in the smaller cohort who did not do that. Right. But people exchange that information too. Like, oh, hey, like here's a list of all the best restaurants that are still open, or who are, you know, whether or not they're allowed to be open. So so yeah, I think that's a challenge. And a lot of the evaluation being done is not quantifying that. They're still treating every place as like independent, but we know that they're not independent from each other, right? So I think that's part of the issue is the methods is pretty new. Like those methods are, you know, maybe in the past 5 years have really took off. And some of the best work is not in the US. So it's, I think pulling in those methods is another big part of what we have to do here.
I have to, anecdotally, I've been thinking a lot since you flashed over it about some of the spillover effects. I used to do a lot of work on the US-Mexico border around El Paso, thinking a lot about, we tend to think of, you know, this fortified, militarized border between the US and Mexico, and therefore these are very distinct places. But in fact, there's a zona fronteriza in which people are within 30 kilometers or so of the US border. There's an internal border that no one ever talks about, but that's actually the real border functionally. And there's a lot of people who function across the US-Mexico border, so the official national border, with an enormous amount of permeability. And that I am sure has been continuing during the COVID pandemic, but I would imagine it's going to wreak havoc on an awful lot of analysis that happens about, you know, the patterns in Texas, for example. I've also been watching people who have been, you know, it's been a story in the Trib quite a bit lately, but people who have been crossing all kinds of borders to get more access to vaccines. A coworker of mine who wasn't eligible here in Chicago, but found out that if she went to Wisconsin, where demand was lower, she could get her vaccine right away. And so she and her family hopped in a car, all these folks driving to Quincy from Chicago and so on, as ways of getting access to the vaccine. Which I just think,
I've heard similar stories, like trips to Ohio or Carbondale. It's like 6 hours, right?
Yeah.
And I mean, California, Arizona, like there were stories of 3-hour trips for a haircut, right? And so, but I think that's where part of the issue is, like, we're really not at a state of equilibrium. So like, normally you might say there's a 60-mile threshold of how far you're willing to travel for a service. But now, like, what is that threshold? 6 hours, right? It's a really different, and now people have time on their hands, right? So you can work everywhere remotely. So, you know, yeah, that's a very different approach. Yeah.
This is a bigger question than we have time for, but at some point I'd be really interested to, I mean, one of the things that comes along with a national crisis and a pandemic like this is we do have this sudden massive influx of public health data that we didn't have before. And as you've said, you know, some of the methods you're using are 5 years old. I have to imagine that some of the methods that people are using and some of the insights are 5 months old at this point. So it'd be interesting to hear at some point how is the field changing because of what's been necessary to happen to analyze this pandemic and this data event, because this is a massive global data event such as we haven't had, you know.
Yeah, I think that last year, if you'd asked me at this time last year, I would have a very different response than right now. So I wonder how that's going to change 6 months from now. Yeah, I think initially in the pandemic, there is this massive effort to kind of work across disciplinary lines. And I mean, they were last March, like with a group in Wisconsin, we were meeting every single day at the same time, right? Like, and it was almost like a support group at a certain point because we just needed to like do something, right? So I think initially there was this huge push to kind of do cross-disciplinary work and that sort of thing. But I think at this stage, there is kind of this backlash in a sense where people have gotten way more specialized and way more competitive than they were when this started. So I mean, I think there's like tens of thousands of dashboards that have emerged because we were just finishing up a paper on that, and that's what one of our colleagues had found. And then there was another article, and this was a few months old, but there were like 60,000 peer-reviewed articles about COVID in the first year, right? So, and it was strange because when we worked on this last year, there were a few collaborators who didn't want to work with us because they wanted to get their paper out to, you know, the highest impact journal as soon as possible, right? So I think, but I mean, part of that reason I get too, because like not everyone's job is totally secure. So there's this shift to kind of competition and moving away from, you know, Unity, whatever that was going to be, towards that. So, and then also specialization of methods, because that's grown, you know, even stronger. So on the GI science side, I've seen a lot of really amazing, stellar work, but in very specialized fields, like mobility patterns in the greatest depth possible, and that sort of thing. On the flip side, there is a lot of attention to how do we integrate social determinants of health into everything that we do. I've been getting a lot of emails from the private sector lately about this, and I'm a little bit concerned potentially that some of that is being privatized, where a lot of it's data wrangling. I don't know. I think there's like a big question that our fields have to make in the next year, that it's kind of like that, what's that expression, come to Jesus moment? Like what's really important, what matters, and that kind of thing going forward. Yeah.
Great. Well, this has been such a great conversation. Went 6 minutes over, so I apologize. But just to close it up, I want to say thank you again so much for coming and talking with us, Marynia, and you guys for joining us. And all of this event is getting recorded and will be posted on our website, Chicago Studies, in the next week or so. And we also always add supplemental materials on the topic. So things Marynia touched upon, you can also find there. And then, of course, I always plug our other upcoming events. So this Friday, we have an event. We call them Chicago Conversations, and this one is on the future of Chicago small businesses. So we're actually talking with a small business owner in Andersonville, which is a neighborhood on the north side that has tons of small businesses. And they're just going to talk about how the pandemic has affected owning a small business and essentially how the neighborhood has supported them and how they're looking to the future. So if you guys are free on Friday, we would love to see you there. And yeah, thank you again for coming and have a great evening, everybody.
Thanks for the great conversation.